Hello, coders. We are looking at the last section of surgery, which is eye and ocular adnexa and the auditory system. Now, the biggest thing before we get into either of these systems, keep in mind, both of these systems are very small, physically small. Again, the eyes are much smaller than most of our major organs, the spleen, pancreas, etc. They're even smaller usually than our ovaries. So that's the biggest thing to keep in mind. The other thing that we want to keep in mind is the separations of the parts of the eye and the parts of the ear as well. Now, there's not a ton of guidelines here for these sections. So before we get into this, the biggest thing is don't forget page 422 in your CPT book, there is a lovely picture of the eye anatomy. Okay, now one of the things that you may want to do is become very familiar with this picture. Remember that there are other pictures we're going to look at, including the extraocular muscles. Don't forget, depending on the ICD-10 and HCPCS book that you're using, you might have better pictures of the eye as well. So don't forget, okay? So we want to keep in mind, we're going to have different parts of the eye to deal with. So we're going to have the eyeball itself, the anterior segment, the posterior segment, and the adnexa, which is the extraocular muscles, orbits and eyelids, and the conjunctiva. So as we go through each and every section, we're going to talk about what we're going to find. Like most surgery sections, 3 easiest ways to find these codes: by the procedure name, like keratoplasty, the anatomic site like eye or adnexa or orbit or eyelids, or the condition like strabismus, okay? So the main terms for this system are going to be the big ones. The different parts that we have: the eye, the ciliary body, conjunctiva, cornea, cataract for our condition like strabismus, the iris, the lens, the orbit, the retina, the sclera. We can also look under eye muscles, eyelashes, eyelid, prostheses, which we're going to talk about, including ocular implants and strabismus. So those are all of our main terms. So what we're going to do is we're going to look through all the eye and ocular adnexa information, then we're going to come back and we're going to talk about the auditory system as well. So we're just going to scroll down here. Okay, so this starts on page 423. So let's talk about the differences between these 3 big codes. So we have evisceration, enucleation, extenderation. Now, basically, as we go up numerically, we go up in complexity and how much we're removing from the body. Now, before we get into these, the biggest thing to keep in mind is we do not remove the eye unless absolutely necessary. So there are 2 most common reasons for removing the eye. Number 1, traumatic accident and injury. And number 2, different types of cancers, things like retinoblastoma, which is a childhood eye cancer. So those are the 2 big reasons. So again, you're not going to see these too often, but you never know when they're going to show up on a certification or credentialing exam, and you want to know what the words mean. So the word evisceration of ocular contents, okay? So that is your key term there. These are muscles and sclera intact. So what they're doing is they're just removing the eye, okay? Just removing the ocular contents itself, okay? They're leaving the sclera intact in the back of the eye, and they are leaving all the muscles, okay? And they can do this with or without an implant. Now, again, depending on the reason why we are doing this, doing the removal of the eye, is whether or not we can implant a prosthetic that day or not. Okay, that's the big thing. So, for instance, I knew someone who had retinoblastoma as a child, and what had happened was it started in their left eye and spread to their right eye. So they had to do the enucleation, which we'll talk about in a minute, to remove the left eye and radiate the right eye. Okay, but because they're dealing with cancer versus something else, they actually had to wait to eventually put in the prosthetic eye because they had to finish the treatment. Same thing with certain accidents and injuries. Again, depending on swelling, if someone gets hit in the eye with, a ball, a baseball bat, anything that's really a hard object or piercing object, it really is going to depend on how much damage there is and how much swelling there is at that time. So That's why we're going to see that we have the removal of the eye with and without implants. And then on the same page, a little bit lower, secondary implant procedures for those patients that can't have the implant put in at the same time of the removal, okay? Now, the enucleation of the eye is the orbital structures are intact, okay? So they're taking out the muscles, they're taking out the sclera, they are taking out the actual ocular contents, okay? So the only thing they're leaving in there is the orbital structures, which itself is really just the cone of the bone of the eye, okay? And again, sometimes we leave some of the muscles intact, sometimes we don't, depends on how many muscles have been affected by the issue. Again, we can do muscles not attached to implant and muscles attached to implant. So we have a couple of different types of prosthetics we're going to talk about in just a minute. Then we get to the extentoration. So extentoration is we are removing the orbital contents, which is the removal of the eye, the muscles, and the bony orbit. Okay, so keep in mind, this is, again, going to be more for traumatic accidents and injuries when there's been perhaps a crush injury or something of that nature. And again, we can do it with the removal of the bone, and we can also do it with the muscle or myocutaneous flaps. So that's one of the biggest things to kind of keep in mind, is that, you know, we have different options depending on what's going on with the patient. Now, when it actually comes to the eye itself, we have ocular implants and we have orbital implants, as well as fully prosthetic eyes. And that's what we're going to see down here, okay? An ocular implant is an implant inside the muscular cone. An orbital implant is an implant outside the muscular cone. So this is what we're going to do. We're going to do what I like to do. We're just going to go and we're going to Google search, okay? And we're going to do, let's see, ocular implant versus orbital implant. And then I'm going to go to images. Again, depending on how much we've removed from the eye is going to be what the person necessarily needs. So let's look at this picture. It's a great picture right here. I like this. Now, I have actually personally known people with both major, both the prosthetics and the orbital and ocular implants. So depending on how much we have to remove from the eye. The orbital implant is basically a round ball that actually fits in where the eye would be and is connected to the muscles, okay? And the muscles hold this ball in place. But what you don't see is that inside this ball, usually there's a little hole that's drilled. Sometimes there's not. It depends on the exact type of prostheses. But what they do is this part can be an eye cap, like you see here, or it can have a peg where the peg inserts directly into this area. So these are the orbital and ocular implants, okay? And these are done when people still have intraocular muscles. But for enucleation and extentoration, they don't always have this. So that's where we get the actual prosthetic eyes themselves. So again, let's look at this. So this is the ocular prosthesis. You can see it's curved, and this is the orbital that's pre-placed, and this fits with this. Again, the difference between these and a typical prosthetic eye, so we're going to do so a prosthetic eye, again, is going to be very different. And actually what I'm going to do, these can be made, by the way, of glass or plastic. So I'm going to put in glass so that we can kind of get a better view of this. So again, these are all different prosthetic eyes. They fit directly to the patient. And so you can see, again, a whole bunch of different ones here. And they are painted so that the person, it basically matches their other eye. It's usually hand painted. And by the way, the hand painting for these comes in the musculoskeletal section under the prosthetics, the facial prosthetics. So kind of keep that in mind. Now, the other big thing to keep in mind about these, again, these are the glass ones that can be also made out of plastic. And it all depends on, again, the size of the patient, the reason for it, stuff like that. So, keep this in mind that you may not even notice that a patient has an eye prosthesis because it's so lifelike. It looks so real, and it's painted so that it has the iris colors, so it looks like the other eye. It also is going to have, you can see if you look here very closely, they actually paint little arteries as well. And if you want to know more about this, my suggestion is you can probably YouTube it, but there is a show called How It's Made. And they've done quite a few different prosthetics pieces. So there's one that you can see about a prosthetic ear, there's one you can see about a prosthetic eye, and they're super interesting, so you can kind of learn a little bit more about this. But the big thing is, what type of implant are we doing for the patient? So again, we can do a modification, okay? So again, they fit it to the patient, but sometimes it just doesn't fit, it's not as comfortable, so they can modify it. They can also do the scleral shell. Again, they can do it with or without the muscles attached, and they can also do a removal as well. So again, it all depends on what's going on with the patient, how much we've removed already, and again, depending on the reason for the removal is whether or not we can do that implant on the same date. Okay, other things that you're going to see, which is over here, you can see right up here starting at 65205, removal of foreign body, but we have a couple options. We have superficial external eye, conjunctival embedded, corneal without slit lamp, corneal with slit lamp. So a couple things I want to go over before we move on, just as a reminder. Number one, primary care physicians, family physicians, GPs, they only deal with very basic eye problems. They will deal with an ingrown eyelash hair. They'll deal with things like styes, conjunctivitis, pink eye, basic infections, okay? Again, if you have like an eyelash stuck under your eyelid, things like that. But when it comes to foreign bodies being in the eye, they usually send that either directly to an ophthalmologist or directly to the ER. Every single office I've ever worked in, that was our policy. If there was something in the person's eye, we would send the call to the nurse, and 99 times out of 100, they would be sent to the emergency room or directly to the ophthalmologist. Because remember, scope of practice. Primary care physicians, general practitioners, and a lot of specialists, they know how to do an eye exam to see what your vision is, but they don't want to get involved with your vision. That's not their specialty. And so, again, you may work in a field where you see this a lot, or you may never see it. It all depends on who you work for. The other thing is that it depends on what's kind of included in your area. Meaning, do you have more ophthalmologists? Do you have, are they surgeons? Are they not surgeons? Are they specialty surgeons? And what age do they deal with? So a lot of times people confuse optometry with ophthalmology because a lot of ophthalmologists have optometry in their facility where you can buy a pair of glasses when you go to their office. In my area, the children's ophthalmology does that, where they have the actual ophthalmologist and they actually have an optometrist where they can sell you the lenses and glasses right in the office itself. However, not all of those ophthalmologists do pediatric eye surgery. Depending on what the child needs, they may have to go to a specialist, and they may have to go to a specialist out of state, depending on where you live. If you live near a larger city, Boston, New York, Chicago, LA, Houston, Miami, anywhere that's considered a large city, hopefully there's going to be a specialist or a subspecialist in that area for things like children. But it depends. As of years ago, there was really only two places that saw children with retinoblastoma. It was Boston Children's Hospital and the hospital associated with Penn State in Philadelphia. But now there are many other facilities that deal with retinoblastoma now. So again, you know, we have to be careful because ophthalmology is such a very specific specialty. They deal with very specific problems and they do a lot of consultations. But keep in mind, this is the surgery. If they're seeing patients in their offices, then we have codes in medicine for the office visits. And if they're doing a consultation, those are going to come from E&M. This is just the surgery. Now, as we go through, so again, the eyeball is exactly what the eyeball is everything that is considered part of the eyeball. Now, the anterior segment, which comes next, involves the cornea, anterior chamber, anterior sclera, the iris and ciliary body, which remember the iris is the color of the eye, and the lens. And it also has some intraocular lens procedures. So it's not surprising that one of the first set of codes we're going to see is for the keratoplasties here, okay? Now, again, this is when we are removing the cornea. And usually we're removing the cornea, again, for a specific condition, like a cataract. So, they tell us corneal transplant includes use of a fresh or preserved graft. The preparation of a donor material is included for penetrating or anterior lamellar keratoplasty, but reported separately for endothelial keratoplasty. Do not report 65710 to 65757 in conjunction with 92025, because if we go to 92025, yet again, this is ophthalmology. 92025 is computerized corneal topography, unilateral or bilateral with interpretation and report, because that is included in this. So this means we are removing the cornea and we are transplanting the cornea. This is similar to like an implantable contact, okay? So they do this for a variety of reasons. We need to know what type are they doing. Is it an anterior lamellar? Is it penetrating? Except for aphakia or pseudophakia. So aphakia means they do not have a lens. Pseudophakia means they already have an implantable lens. Okay? We have penetrating in aphakia, penetrating in pseudophakia, which is why we can't code it here because we have 3 separate codes, and the endothelial as well as the endothelial allograft. So again, this can be done for so many different purposes. It's also done for things like dermoid cysts on the eye. So the problem with a dermoid cyst on the eye, it's a congenital condition, is that it sits on top of the cornea. And so the only way to fix that issue is to remove the cyst and do a partial corneal transplant. And again, that could impair a child's vision. So a lot of times they don't do that unless the cyst itself is giving them problems. Now, as we continue going through the cornea, then the anterior chamber, then the anterior sclera, then the ciliary body, and the iris, specifically, what are we doing to these different parts? Okay, and I always say we need to know the exact anatomic site of the eye. And we need to know that because, again, when it comes to the eye, everything is very close together. We need to know exactly what we're doing and exactly where are we doing it to. Now, when it comes to the lens procedures here, okay, so this is on page 427. There are some incisions which are dealing with dissecting secondary cataract, but then we get to the removals, okay? So under removal, it tells us lateral canthotomy, iridectomy, iridotomy, anterior capsulotomy, posterior capsulotomy, and the use of viscoelastic agents, enzymatic xenolysis, and use of other pharmacologic agents and subconjunctival or subtenon injections are included as part of the code for the extraction of the lens. So, again, these are going to be removals of the lenses themselves. So these are just pure removals, okay? So what we're doing here is we're removing the lens for a specific purpose. So how are we removing it? We also have intracapsular and extracapsular cataract extractions. So, excuse me. Again, how far into the eye do we have to go? How are they describing the cataract? Okay, so in this case, the diagnosis helps us with the procedural coding. Then we get to the actual intraocular lens procedures. In the intraocular lens procedures, again, these are basically we're removing and replacing. So these are getting kind of like the implantable contact after we remove the cataract. Now we have 3 codes here, and you'll see that I'm going to make this just a tiny bit smaller so that all of them fit on one page, so you guys can see them all at once. So we have 66982, 66983, 66984. So 66982, you'll notice I specifically highlighted extracapsular cataract and then complex and wrote ECCE complex. Because even though it says extracapsular cataract removal, this is best known as extracapsular cataract extraction. That's where ECCE comes in. Extracapsular cataract extraction. Now, the difference between 66982 and 66984 is the complexity. Okay, so for 66982, they need to be talking about something that is much more complex. For instance, irrigation, aspiration, phacoemulsification, using devices not generally used in routine cataract surgery, like an iris expansion device, suture support. So again, this is a big part of it. The most common code that you're going to see between these two is going to be the 66984, the cataract removal with insertion. However, again, how does the surgeon describe the complexity of these issues? And then, so these are both for extracapsular cataract extractions. If we are doing an intracapsular cataract extraction, it's an ICCE, and we use code 66983. So I always want to make sure that we are careful. Is it an ECCE or is it an ICCE? Now, as we continue on in the ocular system, we're going to get into the posterior segment of the eye, which is the vitreous humor part. It's also going to talk about the retina and the choroid. And then we get to page 429 where we have the prophylaxis. So it tells us codes 67141 and 67145 include treatment at 1 or more sessions that may occur at different encounters. These codes should be reported once during a defined treatment period. Okay, so coded once during a treatment period. That means the provider has to define the treatment period. That could be a day, could be 3 days, could be a week, could be 2 weeks, could be 3 weeks. It doesn't matter. We only code it out once per treatment period. Now it goes on. Repetitive services. The services listed below are often performed in multiple sessions or groups of sessions. The methods of reporting vary. So, again, be careful about the rest of these codes. The following descriptors are intended to include all sessions and defined treatment period. So again, we have the prophylaxis for retinal detachment. So again, for these, we can be using either cryotherapy or diathermy, hot or cold, for 67141, or photocoagulation, which is laser or xenon arc, which can also be hot or cold. So again, we have to be careful. For the destruction procedures, so this is the deal with retinal detachment. For the destruction procedures, again, we have 67208, 210, 218, 220, and 229. Include treatment at 1 or more sessions that may occur at different encounters. These codes are to be reported once during a defined treatment period. So again, the provider defines a treatment period, we code these once. So this is everything from, again, destruction of a localized lesion. It goes further on. We can do this for different types of retinopathy, lesions of the choroid. So again, we want to be careful that we're doing a destruction procedure. Now we get to the top of page 430. Now we're moving towards the ocular adnexa itself. We have 5 intraocular muscles, okay? We have the superior and inferior muscles. So we have the superior rectus, inferior rectus, lateral rectus, medial rectus, and the oblique, which is actually just one muscle. Even though we have a superior and inferior, it's the same muscle. These 5 muscles are what keeps our eye in our orbit. Now, obviously, because of traumatic accidents and injury, depending on what else is going on, is going to depend on whether or not these eye muscles get dislodged. So, you know, the biggest thing that we want to keep in mind is usually we're just repairing these, but sometimes the eye gets dislodged from these muscles because of the force of a traumatic accident or injury. The first thing we're going to see here is strabismus surgery. So strabismus, again, we're going to go back to Google here, is when the eyes do not face forward. So the pupil aren't looking straight forward. The problem is it can impede vision. So this is esotropia, when the eyes both face in. I have a sister that was born this way and she had the surgery. We also have exotropia. This is a good one. I like this picture a lot. So again, esotropia faces in, exotropia faces out, hypertropia is up, hypotropia is down, and we have all different versions of this. Again, it can be unilateral, it can be bilateral. You can have a right esotropia and a left exotropia, you know, so it can depend. And usually the problem behind these are going back to those extraocular muscles. One of them is too long, one of them is too short. So for one of my sisters, her medial rectus muscle was way too short and the lateral rectus muscles were too long. So what they ended up doing is what you can see on page 431, is they actually cut the muscle, resutured it, so they could put the pupil and the iris facing forward. And this was done when she was very little, around the ages of 2 and 3. So again, you can see here, we need to know which muscles, horizontal and vertical. So I've had students that forget horizontal and vertical. Write it in your book. So again, we always want to remember that there are other terms that we use, especially these mathematical terms that we all want to forget about once we finished high school. The biggest thing is, although we don't use a lot of math and coding, you need to make sure that you know these basic math concepts so that you know what they're talking about. So again, we have horizontal versus vertical muscles and then the oblique muscles. So as we continue to move through the system, the first thing that we want to keep in mind is, again, we have gone from the outside of our eye, so the anterior portion, now we're towards the posterior portion, and then we're going to get towards the orbit and the eyelid. So remember, the orbit are the actual bone that holds the eye in. These guidelines that come are underneath the eyelids. So again, otherwise than the eye itself, the intraocular muscles, the orbit, we also have the eyelids that we're going to deal with. So this is on page 432. And it lets us know codes for the removal of lesions include more than skin, so they can involve the lid margin, the tarsus, and or the palpebral conjunctiva. And then it goes on, for removal of lesion involving mainly skin of eyelid, sends you back to integumentary. So again, if it is on the surface of the eyelids or the lips, and it's just the skin, then we're going to go and we're just going to code from integumentary. If we are excising the eyelids or the lips and we're going deeper into the tissues, we have to go to the separate anatomic section for surgery. Okay, so we want to be careful. Now, I want to show you that this procedure right here, the trichiasis, this can be done by a primary care physician, by a general practitioner. It can be done by an ER doc. All this is plucking out an ingrown hair. Okay, so the biggest thing that we, need to know is this can be done in the office, but it also can be done as part of a larger procedure as well. So again, we have forceps, which is just pulling it out, or by things like epilation, where we actually go in, like it says, the physician uses a biomicroscope and forceps to remove the offending eyelashes. Then cryosurgery, electrosurgery is used to destroy the follicles. So again, if we're going and destroying the follicles, That's 67825. If we're just going in to destroy the actual, or to, I should say, remove the ingrown eyelash, then we're going to just use 67820. The other thing that I want to talk about is to keep in mind the eyebrows, okay? So the eyebrows themselves, again, we have to remember that when we're born, we don't quite have the little fat pads that we're supposed to have underneath our eyebrows, but they grow there as we start aging the first couple months of life. Well, as we start getting into middle age and we start getting to retirement age and things like that, those fat pads can actually wear out quite a bit, and then the skin can actually start sinking down towards the eye. And this is where we're going to start seeing code 67900, the repair of the brow ptosis, blepharoptosis, lid retraction, echotropion, and entropion. So again, these are all different issues with the brows and the eyelids collapsing on itself so that the person can't see properly. And we do need to go in and correct all of those. And again, we can do these, sometimes it's a congenital condition, a child is born with a droopy eyelid, or an elongated amount of skin on their eyelid or their brow, or sometimes this can happen because of traumatic accident or injury, or just aging. So the biggest thing to keep in mind about the eye is that we also have one more section that we haven't talked about. We have the conjunctiva, which is the outermost portion of the eye, and the lacrimal system. So remember, our tear ducts are part of all of this. So when it comes to the lacrimal system, we can also look up lacrima for this, or lacrimal, and what are we doing to it? So again, don't forget that it's all connected. The eyeball itself and all components, the intraocular muscles, the orbit itself, the eyelids, the eyebrows, the eyelashes, as well as the actual tear ducts, which are the lacrimal glands. So where exactly are we going and what are we doing to that anatomic site? That's the biggest thing that we want to keep in mind when we're thinking about coding for eye and ocular adnexa. Now we're going to go back up to the top for the ear. When it comes to the ear, or the auditory system in general, again, you have a picture on page 437. So let's talk about the different parts of the ear. So the external ear includes the auricle, which is also known as the pinna, which is the ear itself, and the external auditory canal, which is the connection from the outside of the ear to the middle ear. That is the external ear. The middle ear starts at the eardrum, also known as the tympanic membrane, and goes until the oval window. The middle ear includes the three smallest bones of our body. So again, like the eye, we can separate out, the external ear from the middle ear. Middle ear has the three small bones, again, the malleus, the incus, and the stapes. And again, it starts from the tympanic membrane and goes to the oval window. The middle or inner ear starts at the oval window and ends at the cochlea, and also deals with all the nerves that go to the cochlea. So again, we're going to see things like ear, auditory canal, mastoid, because again, that's the part of the skull that's right around this. Tympanic membrane, we're going to see things like myoringotomies. This is where we're also going to see our cochlear devices and issues dealing with the temporal bones as well. So again, not a lot of guidelines here. So you need to know what part of the auditory system are you in. Okay, so again, for external ear, we're going to have incision, excision, removal, repairs. So again, what are we doing? We can do a drainage of like an abscess or hematoma. We also have an ear piercing. A lot of parents have a doctor do the ear piercing for their young children, or if someone has very severe allergies, they might have a doctor do it as well. We can also do biopsies, again, as well as excisions, depending on what's going on for traumatic accidents and injuries. We can remove different lesions, again, with or without radical neck dissection. So again, keep that in mind. We're also obviously going to have removal of foreign bodies. That's one of the most common, but again, we have without and with general anesthesia, depending on whether or not we can just remove it using something like forceps, or do we actually have to knock the person out so we can go in and use other instrumentation. The other big part is what comes under the impacted cerumen, okay? They have revised these codes so many times in the past couple of years that they can get confusing. So here is the big thing. We have two main ways that we remove earwax from the ear, the cerumen. Okay. First way is irrigation, which is also sometimes known as lavage, and it's usually warm water, and we infiltrate the area, and it helps break it up, and then we let it just kind of fall out. Okay. Now, we also, and that's 69209. Then we get to 69210. This is removal of impacted cerumen requiring instrumentation. There's many different pieces of ear instrumentation they can use. They can use different forceps. They can also use different types of ear cleaners. So again, in this case, we're going to go back to our Google, and we're going to look for ear instrumentation. And there's a lot of different little loops and things like that we can see. So again, as you can see here, so we'll look at this. Depending on what they need, we have these little loops which can go in and kind of grab the earwax. You can see we have different types of scissors that can go in. We have other pieces of instruments that can kind of scoop and scrape. So again, we need to be careful. How are we doing this? Are we using basically a flush? Are we using instrumentation? That's what's going to be the big one. Again, these are unilateral. So if it's unilateral, use RT or LT. If it's bilateral, use modifier 50. As we get to the middle ear, again, there's no introductions anymore. However, we do have incisions, and this is where knowing your medical terminology is very helpful. Okay, because we have myringotomies and tympanostomies, and guess what? It's the same body part. Remember, the eardrum uses myringo and tympano. So a myringotomy, or making an incision into the eardrum, versus a tympanostomy, where we're doing something like inserting a ventilating tube. So again, be careful. Why do they use both of these terms in this area? Because they can. Remember, each and every specialty area has their own specialist update this, and they feel that this is fine. A lot of people forget, though, that myringo and tympano mean the same thing. So again, we need to make sure if it is a bilateral procedure that we use modifier 50. That also goes for the eyes. All of these are considered unilateral codes unless stated otherwise. So if we're just doing the right ear, we do RT. If we're just doing the left ear, we do LT. If we're doing both, we're going to use modifier 50. Same for the eye procedures as well. So the tympanostomies are the most common with the insertion of a ventilating tube. However, be careful. This is local or topical anesthesia. That is not the most common. The most common is over here, 69436, tympanostomy under general anesthesia. Most of the time, especially if they're a child, they're going to knock them out because the local anesthesia just won't be enough. We also have some excisions as well. And then we get to the inner ear. So when we get to the inner ear, again, we have to be careful because we want to make sure that we are in the exact right place. So we are going to be talking about the oval window. We're going to be talking about the mastoid area. And we're also going to be talking about, the labyrinth of the ear itself. So we have things like the labyrinthotomy, and again, putting in things like vestibular active drugs. So again, making an incision into the labyrinth. We're also going to see labyrinthectomies, vestibular nerve sections, things like that. Okay. And so when we are dealing with the inner ear, we want to know what's going on. You can see right here, we also have the cochlea. So we also go through our cochlear device implantation, and this is just the implantation. Now, unlike a lot of our other devices, this is something that's permanent. We don't have a removal code for it. So this is inserted, and then the programming, the reprogramming, and the analysis will come from medicine. The last little section here is the temporal bone and metaphyseal approach. And again, how are we getting to the area? We're going in through the ear or in through the temporal bone. So the biggest thing to remember for eyes and ears, exactly which anatomic site, left, right, or bilateral. And don't forget that the last code that shows up in our surgery section is the operating microscope. It's an add-on code 69990. And make sure that you have notated that, because there's a lot of do not reports, because the operating microscope is included in certain surgical codes. Good luck, guys.